Thank you. What's the weather like in Tunis now?
Very
hot.
Very hot, very sunny.
hot.
I mean, we can begin. Or...
We begin?
Okay, yes.
So, on behalf of the organization committee of this webinar and the members of the Tunisian Association of Pediatric Surgery, I would like to express my sincere gratitude for your presence in this webinar. I think there is 29 nationality registered in our webinar at this time. So I would like also to thank our discounted invite lecturer as Dr. Mondher Haddad from England and Dr. Sawyer from Turkey, and also my friends Dr. Qsia Amin and Monastir, Tunisia, and Dr. Qarqni Yusra, Tunis, Tunisia. And finally, so I must thank our partners, InfoPoint event organizer and Dahlia Laboratory. I would like in another hand to thank all the members of the board of ATCP board association, Tunisian Association of Pediatric Surgery, who contribute to the organization of this webinar. I could Dr. Nwira, Dr. Benzaou, Dr. Shariag, and Dr. Yusra Ben Ahmed. And also with the coordination of the National College of Pediatric Surgery, and at his head, my friend, Dr. Riyad Jwini. So to organize this webinar, we have all the program with Mondher Haddad, with Dr. Sawyer, Dr. Yusra Qarqni, and after Dr. Qsia. So for the question, you have to click on the button Q and A, and all the questions should be asked at the end of all the lectures. So I will share my presentation to introduce this webinar. You see my presentation?
Yes, yes, we can see it.
Okay, so as you see in the Monastir with the ribat, if you know Dr. Haddad, the ribat of Monastir. So donc this time we choose to treat a particular pathology, gastroesophageal reflux disease in children, with the management option of gastroesophageal reflux disease include non-pharmacological behavior intervention, medical therapy, and surgical therapy. Appropriate treatment requires a thorough knowledge of chronotherapeutic principle in order to obtain optimal control of gastroesophageal reflux disease. So for this program, we should this program gastroesophageal reflux disease surgical treatment in children, tips and tricks, and it will be presented by our friend Dr. Mondher Haddad, United Kingdom. Gastroesophageal reflux disease and esophageal atresia, Dr. Sawyer, Turkey. And after updates in gastroesophageal reflux disease in children, Dr. Yusra Qarqni from Tunisia. Stenting in esophageal stenosis in children, Dr. Amin Qsia from Tunisia. Now, without delay, we will begin by our first guest, Dr. Mondher Haddad, and I will let Dr. Qarqni to introduce him.
Thank you, Dr. Sahnoun. So we are extremely honored to welcome among us Professor Mondher Haddad, who was extremely kind to accept our invitation. Dr. Manzar Haddad is well known. He is the senior consultant pediatric and neonatal surgeon at Chelsea and Westminster Healthcare Foundation Trust Hospital and St. Mary Hospital at Imperial College Healthcare Trust. He is an honorary senior lecturer at Imperial College London. He was elected president of British Association of Pediatric Endoscopic 2007-2010. He was also nominated and elected the first honorary president of the Middle East chapter of IPEC in 2015. He is currently the president, British Association of Pediatric Surgeons. He is the chairman of Chelsea Children's Hospital Charity Fundraising for Many Children project, where the charity managed to raise £1.5 million to purchase the Da Vinci surgical robot at Chelsea Westminster Hospital, which is the first surgical robot in the UK dedicated only for the use in children. He agreed to be with us for the Pediatric, Adolescent and Adult Forgot Interdisciplinary Society, which should have taken place in April in Tunisia. But unfortunately, and given the circumstances, this was cancelled. So fortunately, there are these webinars where we can see each other other even online. So welcome, Dr. Haddad. And as we say in Tunisia, Aslema. So your conference is about gastroesophageal surgical treatment in children, tips and tricks. I remind just our dear participants that they can write their questions to Professor Haddad. We will ask them later once the 4 conferences are finished.
Thank you very much, Dr. Yusra, for this nice introduction. And I would like to thank also Dr. Amin and also Dr. Lassad and the whole Tunisian Association of Pediatric Surgery for giving me the opportunity to participate in this webinar. I especially wore a green tie because Tunis is used to be Tunis Aya Khadra, and I think Tunis is still a green country. Can I share the screen now with the presentation?
Yeah. It's okay.
Is it okay now?
Yeah.
Thank you very much. With any surgical thing, it's important to actually understand the, can I go back a bit, one slide?
Yeah.
Yeah, to understand the anatomy of the gastroesophageal junction, and also the strategically located lower esophageal sphincter in the hiatus in between the fibers of the right crust, and also to understand the intra-abdominal portion of the esophagus, which ranges between 1 and 3 centimeters. I'm sure Dr. Sawyer will actually talk about the gastroesophageal disease as well as Dr. Yusra, but I would like to mention that the pathophysiology of gastroesophageal disease, reflux disease, is the pathological effects of the involuntary gastric reflux. And usually it's acid and pepsin, but also can be also alkaline or bile, causing erosive esophageal esophagitis and stricture, and also Barrett esophagitis. And that involves the associated physiological, anatomical, and developmental abnormalities which coexist in children, and that make gastroesophageal reflux disease and its consequences much more complex. Usually gastroesophageal reflux in comparison with the disease is a physiological thing, and 2/3 of children with gastroesophageal reflux will be spontaneously cured and resolved from the symptoms by the age of 2 years, regardless of any medical treatment. While gastroesophageal reflux disease is pathologic and is associated with failure to thrive, respiratory complications, apparent life-threatening events, and also require medical and or surgical treatment. I know that you're all aware of the frequency of symptoms in children with gastroesophageal reflux disease, and the diagnostic evaluation, which is very important. Once you have suspected that from clinical history and physical examination, usually upper GI contrast studies is performed, and 24-hour pH monitoring is a gold standard. We used to have gastroesophageal scintigraphy like milk scan or apple juice scan, but these have proved to be of less sensitivity and specificity, so it fell out of favor. Nowadays, or recently in the last 5 years, we use the multi-channel intraluminal impedance because that is important to record acid as well as non-acid reflux. Also, we can use manometry and electrogastric graphy and mucosal biopsy, and also the bronchoalveolar lipid-laden macrophages by doing biopsy. But a lot of centers now are going away, or which is fell out of favor. Now, what is the management of this? Either by non-operative management, which is the postural therapy and dietary modifications, and the pharmacological options, which I'm sure the speakers will deal with that, but it's mainly the prokinetic agents as well as the acid-reducing agent. And I would like to mention only about cisapride, which is not used nowadays in children, but it used to be very effective about 20 years ago. The second thing is the operative management, which is the surgical management of gastroesophageal reflux disease. And the indications for that is failure of medical treatment, which is associated with growth failure, respiratory symptoms, and other signs or symptoms such as pain and esophagitis. Also, severe steroid-dependent asthma associated with gastroesophageal reflux, and the presence of Barrett esophagitis and esophageal stricture, and also the association with hiatal hernia and symptoms. The actual goal and principle of anti-reflux procedure is to eradicate the reflux of gastric contents and create a valve mechanism at the gastroesophageal junction, which we know it is a wrap or fundiplication, and this will act as also promoter for gastric intake. The principles is the restoration of the high pressure zone of the lower esophageal sphincter and having a normal location of the lower esophageal sphincter and enhance the angle of Hess and enough intra-abdominal length of esophagus. We used to say at least 2.5 centimeters, but I will mention that it's not necessary at the moment, but you have to have about 1.5 to 2 centimeters length intra-abdominally of the esophagus. These procedures are either complete wrap or partial lap or non-wrap at all, and then it depends on how do you proceed to do this, whether it's open, whether it's laparoscopic, and also nowadays the robotic approach. For the complete 360 posterior wrap, Nissen's fundiplication is the most common procedure nowadays, also laparoscopically and robotically. Nissen's or Randolph Nissen's described his procedure in adults in 1956 but he used to actually do fundoplication earlier, about 1950 or 1949. And currently, as I mentioned, laparoscopic Nissen's fundoplication is one of the most commonly performed procedure in children for gastroesophageal reflux disease treatment. Just to mention that in December 1948, Nissens admitted Albert Einstein for an abdominal surgery because Einstein, as well as having a triple aneurysm, abdominal aneurysm, he had gastroesophageal reflux disease, but he refused to have Nissen's fundoplication, which was described by Randolph, but he agreed to have the abdominal aneurysm actually treated by Nissen, and he actually managed to wrap the aneurysm with a silicone, and Einstein recovered from the surgery and lived a few years afterwards. What I'm going to talk about is the laparoscopic Nissen's fundoplication, which I do, and it's the most common. We used to have it open, then in the 90s, we started to having it laparoscopically, and lately in the last 5 years, we started to carry that as a robotic procedure. Usually the theater setup is that the surgeon is at the bottom end of the table, but in certain special cases, like with cerebral palsy, with kyphosis and other sort of contractures, we used to stand on the right side of the table. And the monitor usually is opposite and the assistant on the left-hand side. And usually we have a special Nissen's tray, and we have insertion of the ports, and usually the instruments contain sort of scissors, liver retractor, diathermy, whether you use the hook or the ultrasonic shears, grasper dissector, needle driver, and usually a 5mm scope. And I usually use the 30-degree angle, but some people use the 0 degree. And this is the setup in a way in the theater, and this is the port sites. And the procedure is carried out under general anesthesia with endotracheal intubation. Usually the bladder is or should be emptied, and as I mentioned, whether supine position, and we prepare the abdomen. And hopefully the video will work. Hooray, yes. We start with actually dissection of or division of the gastrohepatic and the gastrophrenic ligaments, and dissection around the gastroesophageal junction. You can use for diathermy purposes either the hook or any other devices like the harmonic knife or the ligature. And you make sure that when you do the dissection, you avoid the vagi, both the anterior and posterior vagi, and protect them, and also avoid sometimes the aberrant left hepatic artery, which can cause profuse bleeding, which you would like not to happen. And then once you carry out the dissection, you go circumferentially around the esophagus, and also go to the other side where you can identify the spleen. Usually we use a liver retractor, the Nathison's liver retractor, and some people, this is one of the earliest videos, we use some sort of retraction around the esophagus, but you don't need to do that, but it's entirely up to you. Now, also, a lot of people see if they can preserve the short gastric, but in the majority of cases, you need to divide the short gastric so you can have a good floppy fundus to actually wrap. Now, the dissection of the right crust, and you can see here the vagus nerve, posterior vagus nerve very clearly, and you have to avoid that and protect it, and do a little bit of dissection into the right crust, the two leaves of the right crust prior to approximation. In the past, we used to have a very elaborate dissection, but I think nowadays it advised that we need to have minimal dissection. And you need to approximate the two leaves of the right crust or the hiatus. And I usually use the 2O ethibond, and it's easier to have the sliding knot in this so you can make sure that this is stable. It shouldn't be very tight because the more tight it is, the more problematic regarding reflux or regarding dysphagia. I usually put 1 or 2 sutures in there to approximate, and then identify the part of the fundus which I am going to wrap posteriorly, and to divide the upper part of the short gastric vessels, and then get the fundus very comfortably behind the esophagus. And this maneuver, as people describe it, the show shine maneuver. So, and you need to actually have that at ease. And if you just leave both of them, they should stay in place before you actually do the suturing. Usually I put 3 sutures. The first one is only in the stomach, so from the fundus to the other side of the fundus, and then you can mobilize it up and down to stabilize or to make sure where you are going to actually locate the wrap around the lower end of the esophagus. The second suture, you incorporate the esophageal wall, making sure you don't actually get into the esophagus or perforate the esophagus or even stitch the nasogastric tube, and that did happen. So just try to avoid that as much as you can. I usually put a instrument in there to make sure that it's a floppy one. Now, in these cases, if you are going to do gastrostomy, I would advise that, and I will just show you how do I do it. I advise to do it at the same time if it is indicated. And I usually put a circumferential suture, then put diathermy in there, then insert a needle, then a dilator to actually dilate the site, then insert the part of the tube that I'm going to use. Then the 2 ends of the suture, I bring them up into the anterior abdominal wall. This is the tube that you can see, which is going to stay there. It's the Mickey. And then these are the 2 ends of the circumferential suture. You bring it out and you actually invert the edges of the opening, so to prevent leak, and then you tighten it up like an ink well, and you tighten it and tie it around the flange of the Mickey or the procedure that you, or any of the tubes that you want to use. And I leave that for about 5 days. This is the Mickey, and that's the way that I do the gastrostomy. Now, do we need to do a gastrostomy in each? No, but in certain cases, yes. If you are using a bougie, this is just an indicator of the size of the bougie that you can use against the weight of the child. The surgical complications, either the intraoperative complications, which include bleeding, gastric and esophageal perforation, pneumothorax, or vagal nerve injury. The post-operative complications, either delayed gastric emptying, but this is due to a pre-existing condition. If you do Nissen's fundoplication on a normal stomach, that actually increase or promote the gastric emptying. The other complications is dysphagia, and usually in 360 degrees, if it is very tight, it will actually cause dysphagia. The late complications is failure of fundoplication due to a RAC disruption, and usually that occurs in about 2% of cases. Also, the neurologically impaired people, they have, or children, they have a recurrence rate of about 12 to 15%. I just want to say that there are so many procedures and modifications which one actually is sort of facing. There is still no true international consensus on the basic technique of total versus partial fundoplication. And the question there is, total fundoplication more durable? Is total fundoplication more likely to cause post-operative dysphagia, or is partial fundoplication ought to be reserved for those with achalasia or sclerodermia or previous tracheoesophageal fistula repair? Now, there are more queries, and I would like to probably you to be aware of these, but also we try to answer them as we go. It's, is failure of treatment a real indication for surgery? Is a gastrostomy tube placement always indicated? Is laparoscopic fundoplication better than open? Does fundoplication decrease the rate of hospital stay or admissions for respiratory symptoms and failure to thrive? Is Nissen's fundoplication the correct procedure that we need to do? And what about the neurologically impaired children? And what about the children with other comorbidities? And is circumferential division of the esophagus or esophageal attachments really needed? How minimal dissection is minimal? And do we really need to divide the short gastric vessels? So what is known so far, that laparoscopic fundoplication is a safe, effective, with less pain and faster recovery than the open. It's always definite that Nissen's, floppy Nissen's fundoplication superior to a tight one, and gastrostomy tube placement is indicated only in those patients who have swallowing disorders or severe failure to thrive. It is not used as a routine procedure to decompress the stomach after a fundoplication. The quality of available evidence is really poor. So most studies are underpowered, retrospective, and have heterogeneous study design, as well as a heterogeneous pediatric patient population. These are some of the papers. I don't want to go through them, but it's okay if you have a look at them and review them. But there has been no prospective studies published so far showing only results in children with esophageal atresia undergoing anti-reflux procedures. or surgery. The only thing which I would like to draw your attention is the minimally versus extensive esophageal mobilization during laparoscopic fundoplication. And there's need a lot of studies and research to do that. I'm going to skip this presentation for the sake of time, and to say that laparoscopic Nissen's fundoplication is takes longer time than open. It's earlier establishment of feeds, less recruitment or requirement of epidural, patient analgesia or nurse analgesia induced, and there's no difference. But we found that cardiac disease is a predictor for failure of Nissen's fundoplication. Nowadays, we do it robotically in robotic surgery, and also there is NOTES, which is natural orifice transluminal endoscopic surgery, and that is done through the esophagus by introduction of such an instrument, and resuturing around the gastroesophageal junction of the cardia to actually tighten it and reduce or treat the reflux. This is not used commonly, and we had some problems with that. It can't be used below the age of 10, and also there has been perforation of the stomach and the esophagus complicated with peritonitis and sepsis. The take-home message I would like to say that poor quality of available evidence, partial fundoplication is probably as effective as total. Total fundoplication is more durable and results in more significant dysphagia. Mixed results regarding the neurologically impaired patient, and extensive mobilization of the esophagus is not warranted in pediatric population. And I will stop here and say thank you. And this is a nice scene from Tunisia. I will encourage people to visit Tunisia. Thank you very much. And I'll be happy to answer any question at the end of the webinar.
Thank you very much, Dr. Haddad, for this excellent lecture and excellent review from Tunisia, from Dr. Haddad. So I let the question in the end of all the webinar.
Yeah.
So I let Dr. Qarkhni to present Dr. Sayer from Turkey.
Dr.
Qsia, I mean. Excuse me, I mean.
No problem. Thank you very much, Mr. President. It's a great honor for the Tunisian Association of Pediatric Surgeons to receive Professor Sayer in this webinar. And personally, it's a great pleasure for me to introduce him. Indeed, Dr. Sayer is working as surgeon consultant at Hacettepe University Swallowing Disorders Research Center. He has more than 120 publications about pediatric surgery, and his research interest is focused on congenital esophageal anomalies, thoracic surgery in newborns and children. Dr. Sayer is currently board member of Turkish Association of Pediatric Surgeons and responsible of educational office. He is a member of International Network on Esophageal Atresia and one of the chairs in the Turkish National Esophageal Atresia Registry. In 2019, he has been selected as member of Network Office in European Associations of Pediatric Surgeons. But more than this, Dr. Sayer is a warm-hearted, friendly, generous person. He's humble, modest, with a high level of scientific knowledge. Personally, I had the extreme pleasure to meet him the first time in Mainz in 2017 when Oliver Monsterer, our dear friend, organized PAFI's meeting, and I was really impressed by his lectures. Certainly, he's one of the great experts in esophageal atresia, because esophageal atresia is not only a professional matter for him, but I know it's a personal thing for him. So we cannot find better than Dr. Sayer to speak about gastroesophageal reflux and esophageal atresia. So thank you so much, Dr. Sayer, for accepting our invitation, and we will listen to you. Thank you very much, Dr. Sayer. Just to tell you that here we will have some question, a pool, and you will select your propositions.
Yes, good evening, everybody. It's a great pleasure and honor for me to participate in this meeting, and I would like to thank the Tunisian Association of Pediatric Surgeons and my friend Amin for his kind invitation to this webinar. It's also a great pleasure for me, and I would like to thank Ms. for his great words and also taking part with the great experts in this meeting. My topic is about the gastroesophageal reflux disease in children with esophageal atresia. As we all know that reflux disease is very common after esophageal atresia, and the incidence is about 22 to 45% of all cases. There are several causes for a baby to develop gastroesophageal reflux. One of them is the anatomical alterations that they have hiatal hernia, shortened intra-abdominal esophagus due to extensive dissection of the distal porch. At the same time, vagal nerve injury and the esophageal dysmotility, which decreased esophageal clearance and increased acid exposure, esophagitis, and the Barrett's esophagus are the other causes of esophageal atresia of the babies with the reflux. This is one of the upper GI studies. I'm not sure. Yeah, okay. This is one of the upper GI studies of a baby. You can see he has a hiatal hernia, and the fundus is almost above the diaphragm. And this is another one, and you can see that this is the result of the delayed primary repair with an extensive dissection of the distal porch. Reflux have several symptoms that cause the early and long-term problems. They are either related with gastrointestinal or the respiratory symptoms. Gastrointestinal symptoms like vomiting, like heartburn are very common, but for EA patients, there are some special problems like recurrent and asthmatic strictures, esophagitis, Barrett's esophagus, and the esophageal cancer. Also, respiratory problems due to reflux are very common. Both reflux and aspiration cause recurrent atelectasis, bronchiectasis, and tracheomalacia, which worsens the symptoms of these babies. This is one of our studies that we evaluated the relationship between the oxidative stress markers in the axillate braid condensate of patients with esophageal atresia. And also in this study, we see that both medical and surgical treatment of GERD decreases the oxidative stress in patients with esophageal atresia. And how about the type of the surgical treatment and the relationship with the GERD? The reflux is more common after delayed primary anastomosis when compared to primary anastomosis in the newborns. Also, reflux is a significant problem after the replacement. It has been reported that the gastric pull-up is with a high incidence is nearly about 44% of cases. And the causes are loss of angle of his, reflux, aspiration, and bulk of stomach in the chest. There is a very good systematic review and meta-analysis comparing the surgical outcomes of different approaches to the esophageal replacement in a long gap esophageal atresia. As you see, reflux has the highest rate in after gastric pull-up when compared to the cooling interpositions, jejunal interpositions, and gastric tube replacements. And how we diagnose reflux in EA patients? We have to keep in mind that children with EA may have reflux without any symptoms. And sometimes we can see that these babies have no symptoms, but they have some recurrent problems or ongoing problems. Therefore, we need to monitorize whether the reflux is the presence of reflux and at the same time the severity of reflux. Then we use pH monitorization and impedance to find the acid exposure of esophagus, non-acidic reflux, and to define the relationship between the symptoms and the reflux episodes. There is a very good another study that comparing the results of the impedance findings in patients with EA and the control group. And it has been shown that the children with EA higher incidence of non-acidic reflux than controls. In the same study, the use of proton pump inhibitors and the long gap and non-long gap groups have no difference. Also, fundoplication and the patients without fundoplication has similar results. But there's a very important finding in this study that showed that the patients with EA showed decreased basal impedance findings when compared to healthy controls. And this is one of the most important reasons that they have postoperative dysphagia in these patients. This is also one of our studies that we presented last year in the UPSA meeting in Belgrade. And we evaluated the results of the impedance findings in our EA patients. And we found that most of the reflux episodes are weakly acidic, nearly half of them. And 30% of them acidic, and 22% of them are non-acidic. And another interesting finding that the reflux material is not always liquids. It is both liquids and gases. And another important finding is that the most of the proximal extent of the reflux events are related with the respiratory symptoms. So in that study, another interesting finding that in 5 of the 8 patients who had no reflux in conventional pH-metry showed weak acidic and non-acidic reflux in impedance testing. Therefore, we have to keep in mind that weak acidics and non-acidic reflux may be missed with the conventional pH meter, and we need an impedance. And I think one of the most important indications for impedance are the patients with EA. But we have to care when we evaluate the results of our impedance tests, because we know that the basal impedance measurements are 25% less than the controls due to esophagitis or dysmotility in these patients. Therefore, the results can be controversial. At the same time, the reflux episodes can be reported less than normal in EH patients. So the question is that, do we need to perform the impedance testing to all EA patients? I think the answer is no, because the non-acidic reflux is predominant in these patients, and up to now, no precise treatment have been defined for non-acidic reflux, and the clinical use is therefore a little bit limited. Therefore, we need to have to do impedance testing in selected patients. Then my first question is about when do you perform a pH monitoring in EA patients? None of the patients, because almost all of them have already GERD. B, before starting PPIs, or before stopping PPI, or only in patients with recurrent symptoms. I think we're going to have the results.
Let's see the results.
Are we going to see the results now? Okay, I think most of the audience think that only in patients with recurrent symptoms. Okay. Can I go?
Yeah.
But I couldn't change my slides.
Guys.
I couldn't go with the slides.
Just 1 minute.
Okay.
Guys. Guys, il doit repartager, Guys.
Can I continue?
Just a few of seconds. I see with Qais.
Okay.
It's okay. Yeah? Just click in the mouse into the slide. You can change.
Yeah, okay. Yeah, okay. Thank you.
Okay.
Now, there is a very good guideline from ASPGAN and NASPGAN, which is evaluating the results in the treatment of the gastrointestinal nutritional complications in children with esophageal atresia. This guideline is released with a group of experts from the International Network of Esophageal Atresia. And their first recommendation is that pH monitoring can be used to evaluate the severity of reflux and its relation with symptoms. The second recommendation about the impedance is that they can use to evaluate the acid reflux in relation with the extraesophageal symptoms. And the indications are the symptomatic patients under PPI treatments, symptomatic patients with normal pH findings, and atypical symptoms such as acute life-threatening events. And they answer the question, when do we monitor pH monitoring for patients with EA? The first one is after 1 year of age before stopping PPI treatments, before stopping anti-reflux treatment at any age, and in any age if the symptoms are recurrent. And the third recommendation is that all EA cases should be evaluated before stopping anti-reflux medication. And how about the high-resolution esophageal manometry? The use of high-resolution esophageal manometry is limited in these patients, but if you have a baby with an isolated or a long-cap esophageal atresia, the pathologic finding in the manometry will be going to be a peristalsis. If you have a patient with an EA and anti-reflux surgery, the pathologic finding in the manometry will be pressurization. But for the diagnosis, we use endoscopy, very common, and the biopsies during the routine endoscopic evaluation revealed 80% of mild to severe esophagitis in children with esophageal atresia. And the same guideline recommends 3 routine endoscopies during the life of a time with the esophageal atresia baby. The first endoscopy will be after PPI treatment. Second one is before 10 years of age. And finally, before the transition to the adulthood. And how about the medical treatments? The use of antiacid medications in children with EA is a little bit controversial because, as I said, most of the patients have non-acidic reflux, and the effectiveness of the antiacid medications in non-acidic reflux is a little bit controversial, as I said, but still we use PPIs and H2 receptor antigens to control the GI and respiratory symptoms, and PPIs are the first line of treatment. But to use a PPI for a longer time should be evaluated for the effectiveness and the adverse effects at the same time. The second question is that, do you use proton pump inhibitors after esophageal repair? A, only symptomatic cases. B, routinely to all patients until 1 year of age. C, if cure is confirmed by pH monitoring. And if these, the anastomotic strictures are unresponsive to the dilatation treatment. Yes, it's a very good number, I think, because 66% use routinely PPIs before 1 year of age. Okay. And what says the guideline? PPI in esophageal atresia to all patients in the first years of life. And how long are we going to use the PPIs? Stop at the first years of life, or we continue? If the patients with ongoing symptoms and reflux complications after 1 year of age, or there is strictures due to reflux, and since they mostly occur after 1 year of age, we can go with the PPI treatments and we can prolong the treatments. But there's another very good systematic review and meta-analysis that show that the prolonged use of PPI has no protective effect for the esophageal strictures. Therefore, this is another question, how long we're going to use that. And finally, the surgical treatment of reflux disease in EA patients. In 10 to 50% of cases need surgical treatment of gastroesophageal reflux. And when we looked at a large cohort of patients with EA, we find that 9 to 40% has undergone fundoplication in one time in their life. And the indications and the instance of the anti-reflux surgery depend on most of the surgery type of the esophageal atresia. The indications of fundoplication is similar to other children, but in patients with A, the most common indication is the anastomotic strictures. And there is a meta-analysis that showing that the rate of the fundoplication is similar after both open and thoracoscopic EA repair. There is no difference between the rate of fundoplication according to the type of surgical treatment of EA. And the third question is about if you're going to plan an anti-reflux surgery, what is the timing? Before 1 year of age, at any age, or do you postpone as possible as you can, or do you perform it after the complications occur? After the complications occur is the highest rate, 38. The second one is postpone as possible as I can. And at any age is also very close. Okay. The French Esophageal Registry, a very good study from them, is about the predictive factors for needing anti-reflux surgery before 1 year of age. If you have anastomotic tension, if you have associated anomalies, and the birth weights are the predictive factors for needing anti-reflux surgery before 1 year of age. But interestingly, at the same time, the factors that affect the results of fundoplication before 1 year of age is the same: the birth weights, the anastomotic strictures, and the feeding problems. Before planning an anti-reflux surgery to a EA patient, what are the preoperative assessments? In our clinic, we usually almost do an endoscopy to all patients. It's very important because by the help of the endoscopy, we evaluate the structure and esophagitis. In case of strictures, we need to dilatation before doing a performing in fundoplication. We use upper GI series in pH monitoring, and manometry and scintigraphy is always abnormal and no use in deciding, or it's not necessary to do the preoperative assessment. And my last question is about what is your choice in the surgical treatment of GERD in patients with A? Open total, open partial, laparoscopic total, or laparoscopic partial fundoplication? Okay, laparoscopic total fundoplication and laparoscopic partial fundoplication, nearly equal. Thank you for your responses. The partial fundoplication, we know that has less complications, but at the same time, low success rates. And total fundoplications has always complications of dysphagia, choking, and gas blood syndrome. But in the large series, there is no difference between the results of total versus partial fundoplication and open versus laparoscopic fundoplication in patients with EA. This is a study from Finland, and they compared the results of partial and complete fundoplication in children with EA. And there is no difference between regurgitation, dysphagia, retching, and diarrhea after the surgical treatment. And they found that there is no difference between total versus partial fundoplication. What are the complications for EA patients after they have a fundoplication? The idea to wrap the stomach of an impaired peristaltic esophagus is a little bit questionnaire for everybody, and we know that the increased postoperative dysphagia is more common in patients with EA, and 1/3 of the cases have postoperative dysphagia. But luckily, this is resolved by time, and also these patients have some increased respiratory problems due to this motility. But as we know, we always try to do a fallopinism fundoplication, and we try to avoid these complications. When we look at the results of fundoplications in EA patients, the best outcomes are seen, especially if the indication is recurrent esophageal strictures. It has noise only in 1/4 of the cases. The results for the respiratory problems are controversial because the respiratory problems not only related with the gastroesophageal reflux disease, it is multifactorial, and some structural abnormalities causes also respiratory problems. It is unsuccessful in 30% of cases, and the rep failure rate is 20 to 45%, which is common after the postoperative 1.5 year and 2 years of surgery. And the long gap EA has always higher failure rates. This study is also evaluating the effectiveness of anti-reflux procedure in EA. It is very effective to prevent reflux in short term, but by the time they found that the reflux index by evaluated pH meter increases by time, and the body weights, which are low at 1 and 7 years, and they catch up growth and catch their peers at 15 years of age. So performing the anti-reflux procedure as early becomes always a risk of failure of the results or failure of the fundoplication. There are also some several causes for the failure. This small stomach, especially in the isolated cases, and decreased gastric emptying and decreased peristalsis. And we diagnose failure with the upper GI series and pH meter. And if it's minor and mild findings, the conservative and medical treatments are still option. But if we have severe reflux and reflux complications, we need reader fundoplications. The rate of reader fundoplication is 15% in EA cases. They always have longer operative times, have a risk of bleeding, dense adhesions, and technical difficulties. The success rates become to 70 to 80%, and the rep failure is higher than the initial operation, and the overall results are not favorable. I have never used before, but esophagogastric dissociation is another option for the babies who have difficulty to resolve the reflux and avoiding the reflux complications with failure Nissen. And this is another study that they compared the results of reader fundoplications in EA and non-EA cases. There is no significant difference for the rate of reader fundoplications, but interestingly, the duration between the initial and the reader fundoplication is longer in EA cases. Also, some reports says that the long gap is a risk for reader fundoplication, but in this study, they found no differences. And the most important of this study is that we can see that before 2 years of age, if you do a fundoplication, then you have a risk of reader surgery. And my final words is about EA and cancer, which is also related with the reflux. We know that risk of Barrett's esophagus is increased 4-fold in patients with EA, and squamous cell cancer risk increases 180-fold. Therefore, we need a routine endoscopic surveillance that, as I said, the guideline gives us 3 times that we need a routine endoscopic evaluations. And we know that the intestinal metaplasia is 1/3 of cases with a mean age of 10 years, and the gastric metaplasia is about with a mean age of 7 to 9 years. And my last words is I would like to thank Amina to giving me this opportunity to announce the meeting. We're going to organize the 6th Pediatric Adult Forgot Interdisciplinary Symposium in Ankara, Turkey in September. If pandemics will give us opportunity to do that. For now, we're planning to do, and it's going to be a hybrid congress. And the ones who cannot travel to Turkey can have the online registration and follow the meeting. Thank you for your invitation and attention.
Thank you. Thank you very much, Dr. Sawyer, for this excellent lecture about EA with gastroesophageal reflux. So we have many questions for you after in the end of the webinar. And I pass to the next lecture with Dr. Qarqni Yusra. So Yusra?
Yes?
You can begin.
Yes, of course. I share my my lecture. You can see it?
Yes, it's okay.
It's okay.
Just okay, we make it in all the plane.
Put it full screen.
Full screen, full screen. Yeah, it's okay. It's okay. It's okay.
Okay. So I thank again all the participants with us for their presence. This lecture serves as an update for the diagnosis and management of gastroesophageal reflux disease in infants and children, and is intended to be applied in daily practice. Our lecture will focus on researching relevant updates on diagnosis, the therapeutic management, and the prognosis of gastroesophageal reflux disease. We'll start by the diagnosis. In clinical practice, it may be difficult to differentiate gastroesophageal reflux from gastroesophageal reflux disease in children, and the terms are used interchangeably by health professionals and parents alike. Symptoms of gastroesophageal reflux disease are known to vary widely by age and are non-specific. As you can sequence, proving that reflux events cause one or multiple symptoms is often difficult. This is particularly true in nonverbal infants in whom defining troublesome is problematic. Reported symptoms of infant gastroesophageal reflux disease vary widely. So the definition of gastroesophageal reflux and gastroesophageal reflux disease are therefore blurred for the pediatric population, making it difficult to identify infants and children who generally suffer from gastroesophageal reflux disease and to estimate the true prevalence and burden of the problem. So actually, here are the definition, the updates of the definition that we should use. So gastroesophageal reflux is the passage of gastric content into the esophagus with or without regurgitation and vomiting. It's called gastroesophageal reflux disease when it leads to troublesome symptoms that affect daily functioning and or complication. We call refractory gastroesophageal reflux disease when it's not responding to optimal treatment after 8 weeks. And by optimal therapy, we mean maximum pharmacologic and or non-pharmacologic therapy based on the available healthcare facilities. So infants and children present with a wide range of non-specific symptoms that may be interpreted as gastroesophageal reflux symptoms, but the reliability of these clinical manifestations, the consequences of gastroesophageal reflux is not always clear. Guidelines, systematic reviews, and consensus documents has established a comprehensive list of alarm features or red flags that should warrant further investigation by healthcare professionals to rule out complication of gastroesophageal reflux disease. These symptoms are presented in this table, and as we can see, typical symptoms of gastroesophageal reflux disease in older children are the heartburn, the chest pain, and epigastric pain. The diagnosis of gastroesophageal reflux disease is based primarily on clinical suspicion, which can be strengthened by additional diagnosis investigations that are aimed to quantify and qualify gastroesophageal reflux disease. There are no exams that can be defined gold standard investigation to diagnose gastroesophageal reflux disease in infants or children. So we will see the current recommendation for each investigation that can be requested. We start by the barium contrast study and ultrasonography. We shouldn't use them for the diagnosis. We use it to exclude anatomical abnormalities. As for the esophageal gastroduodenoscopy with or without biopsy, review suggests not to use them for the diagnosis. We use them with biopsies to assess complication of gastroesophageal reflux disease in case an underlying mucosal disease is suspected or prior to escalation of therapy. For the manometry and motility studies, reviews suggest not to use manometry studies for the diagnosis and consider the use of it when a motility disorder is suspected. There are other exams that and investigations such as extraesophageal biomarkers, scintigraphy, proton pump inhibitor trials. All these exams shouldn't be used for the diagnosis of gastroesophageal reflux disease. pH metry, we use it only to correlate persistent troublesome symptoms with acid gastroesophageal reflux events. We use it to clarify the role of acid reflux in the etiology of esophagitis and other signs and symptoms suggestive for gastroesophageal reflux disease, and to determine the efficacy of acid suppression therapy. As for the pH impedance monitoring, the advantage above the sole monitoring of the esophageal pH lays its ability to accurately detect reflex weight with pH under 4 or greater than 4, full column reflex weight, liquid and gas reflux, and drops in esophageal pH due to reflux versus swallow-related drops. pH impedance monitoring had a high sensitivity compared to pH metry for the detection of reflux episodes, particularly when non-acid reflux were prevalent. So it will be used for the same indication as the pH metry, but in addition, it permits to differentiate non-erosive reflux disease, hypersensitive esophagus, and functional heartburn in patients with normal endoscopy. We'll see now the second part of this lecture that will focus on research and relevant updates concerning the therapeutic management. Treatment options for gastroesophageal reflux disease in infants include non-pharmacologic approaches, pharmacological therapies, and surgical options. The aim of treatment is to relieve symptoms and prevent long-term consequences of reflux. Clinicians should carefully consider signs of alarm that suggest disorders other than gastroesophageal reflux disease. We start by reviewing non-pharmacological approaches, options. So large-scale evidence to support the efficacy of lifestyle intervention is lacking. However, given the inherently of their low risk, they may be reasonable to consider prior to initiating pharmacotherapy. One study of 15 infants with reflux investigated the effect of 40-day intervention, including a milk-free diet, thickened feeds, anti-reflux positioning, and tobacco smoke avoidance, found that symptoms of gastroesophageal reflux were reduced in 60% and resolved completely in 25% of patients. While it remains unclear which of the above intervention was most effective, this study does lend support to the notion that such changes may provide benefit. So in conclusion, these are the strong recommendations of the North American and European Society for Pediatric Gastroenterology, Hepatology, and Nutrition on non-pharmacological treatment. So there are strong recommendations. So the working group recommends not to use positional therapy to treat symptoms of gastroesophageal reflux disease in sleeping infants and recommends providing patient parental education and support as part of the treatment of gastroesophageal reflux disease. They also provide an algorithm showing the different part of the lifestyle intervention. Because of the high prevalence of gastroesophageal reflux and because of the concerns that have aroused with its pharmacological treatment, it's time to review the best evidence supporting the choice of the best pharmacological option. We can ask about what are the effective and safe pharmacological treatment options for the reduction of signs and symptoms of gastroesophageal reflux disease. A recent French study assessing gastroesophageal reflux in children under the age of 17 years revealed that although only one diagnostic test was performed in 31% of patients presenting with either gastroesophageal reflux or gastroesophageal reflux disease, pharmacological treatment was prescribed in more than 80% of the cases, even the confirmed gastroesophageal reflux. So safety issues related to both short-term and long-term pharmacologic treatment has become a matter of concern. Ideally, the use of pharmacological management should be tried only after failure of maximized and exhausted non-pharmacological strategy. There is not current pharmacological targeting the transient lower esophageal sphincter relaxation, and acid suppressive therapies with proton pump inhibitors and histamine 2 receptor antagonists are the cornerstones to the management of gastroesophageal reflux disease in children. Although their pharmacological mechanisms differ, both of them are acid suppressing agents, and thus similar outcomes can be expected. Rates of healing of erosive or histologic esophagitis are higher after 12 weeks of therapy with PPI in contrast to histamine 2 receptor antagonists. So let's see the expert opinion on pharmacotherapy and the recommendation of the American Society and the European Society for Pediatric Gastroenterology, Pathology and Nutrition about pharmacological treatment. So the working group recommends to use the use of PPI as first-line treatment of reflux-related erosive esophagitis in infants, not to use them for the treatment of visible regurgitation, crying, distress in otherwise healthy infants, a 4 to 8 week course of using the drug for treatment of typical symptoms in children with gastroesophageal reflux disease. We should undergo an evaluation of treatment efficacy and exclusion of alternative causes of symptoms in infants and children not responding to 4 to 8 weeks of optimal medical therapy for gastroesophageal reflux disease. Regular assessment of the ongoing need of long-term acid suppression therapy in infants and children with gastroesophageal reflux disease. So in conclusion, clinicians should reserve acid suppressive medication use for infants and children with proven gastroesophageal reflux disease, especially when they are complicated by esophagitis, to avoid their routine use in patients with merely symptoms of gastroesophageal reflux, where the risk-benefit ratio of treatment is less favorable. These medications should be prescribed only when there is a clear diagnosis of gastroesophageal reflux disease, and whenever possible, the lowest doses should be prescribed for the shortest length of time possible. So regarding the surgical treatment, and after the excellent and brilliant intervention of our two guests, I would add just a few words on the last recommendation in the literature on which only emphasize what has been said. Most of the literature on surgical therapy in children consists of retrospective case series in which documentation of the diagnosis of gastroesophageal reflux and details of previous medical therapy are lacking. This makes it difficult to assess the indication for and responses to surgery. This is why we found weak recommendation in the literature. I'm not going to repeat what Professor Hadid explained very well earlier on the operating indication and the choice of the different surgical techniques. I'm just going to dwell a little on the indication stipulating that gastroesophageal reflux disease should should benefit of anti-reflux surgery when they present symptoms refractory to optimal therapy after appropriate evaluation to exclude other underlying disease, and when they need for chronic, there are a need for chronic pharmacotherapy for control of signs and or symptoms of gastroesophageal reflux. So indeed, by reviewing literature about for how long should we consider pharmacotherapy, we often come across these sentences about acid suppressive medication. It should be used cautiously in infants. The decision to start acid suppressive medication should be made with great care. This decision also needs to be made judiciously. In fact, with the extraction of endoscopically confirmed erosive esophagitis, acid suppressive medication have not been shown to have a beneficial role in gastroesophageal reflux disease, particularly in infants. All this is about the safety data with the treatment of pediatric esophagitis. The low pH of the intragastric environment constitutes one of the major non-specific defense mechanisms So any reduction of gastric acid secretion may increase the risk of infection from a wide spectrum of organisms. Several reports suggest that antisuppressive medication may be associated with the occurrence of infection, such as respiratory tract infection or enteric infection directly as a result of reduced gastric acidity, which in turn may alter the gut microbiome. However, the level of evidence remains weak. The studies that suggest some association are small in number and size, in addition to various methodological concerns. We see here in adult studies some systematic reviews with meta-analysis stipulate that there is the use of long-term use of PPI more than 12 months exposed to fundic gland polyps and even gastric cancer. So what about the recommendation about the use of this acid suppressive medication? So there are strong recommendations talking about the evaluation of treatment efficacy and exclusion of alternative causes of symptoms in infants not responding to 4 to 8 weeks of optimal therapy, and patients cannot be permanently weaned from pharmacological treatment within 6 to 12 months. An additional evaluation should be considered after 4 to 8 weeks of optimal gastroesophageal reflux therapy if clinically indicated. And therefore, there is not really an exact answer on the maximum duration of use of acid suppressive medication. However, after a year of treatment, we really should really be careful. So, what about the prognosis of gastroesophageal reflux? The gastroesophageal reflux disease in otherwise normal children can persist through adolescence and adulthood in a significant proportion of patients who continue to have gastroesophageal reflux disease symptoms and signs and use anti-secretory medication. So childhood gastroesophageal reflux disease is a risk factor for gastroesophageal reflux disease in adolescence and adulthood. This publication talks about the follow-up of a cohort of children and adolescents with gastroesophageal reflux disease who were free of reflux esophagitis at initial diagnosis. And we can see that the age of onset of gastroesophageal reflux disease symptoms under 5 years and the use of acid suppressive at time initial diagnosis may result in less favorable outcome. So, what are the take-home messages? Be aware of alarm features or red flags that should warrant further investigation to rule complications. Barium contrast study and ultrasonography are used to exclude anatomical abnormalities. Use the gastroduodenoscopy with biopsies to assess complication of gastroesophageal reflux disease. Use manometry when a motility disorder is suspected. Use pH metry to clarify the role of acid reflux in the etiology of esophagitis and other signs and symptoms suggested for gastroesophageal reflux disease. Reserve acid suppressive medication used for infants and children with proven gastroesophageal reflux disease. We recommend evaluation of treatment efficacy and exclusion of alternative causes of symptoms in infants and children not responding to 4 to 8 weeks of optimal therapy of gastroesophageal reflux disease. And finally, patients cannot be permanently weaned from pharmacological treatment within 6 to 12 months. And thank you.
Thank you very much, Yusra, for this good lecture. And we must pass for the next lecture with our friend, Dr. Rami Naqsia. He will speak about stenting in the esophageal structure. I mean, your mic, I mean. Okay.
Do you listen to me?
Yeah.
Thank you, Dr. Sahnoun. I will have the pleasure to conclude this webinar presentation. I don't know if you see my presentation.
Maybe, yeah, maybe in a few seconds. Yeah, okay, it's okay. Just close the.
Okay, so
full screen.
I will speak about stenting in esophageal stenosis in children. As you know, esophageal stenting is widely used in adults for malignant and for benign etiologies. Regarding pediatric population, and since its first description in 2005, it's clear that we are facing a different situation. Different situation because we have different etiologies and because the devices that must be used are also different. So with the referral to the literature and to our department experience, we will try to respond to 5 questions. First of all, why esophageal stenting? Second, we will describe some indications of esophageal stenting in children. The third question is a very important question. It's about how to choose the right stent. After, we will describe briefly the procedure and also we'll describe the complications and the benefits of esophageal stenting. Let's begin by our first question. Why esophageal stenting? Nowadays, we are using new devices that are self-expandable. This means that we will have like a permanent dilation. And you can imagine that this can be an interesting alternative to recurrent dilation. We have all in our practice this kind of patients that are refractory to dilation and that need numerous anesthesia, general anesthesia, and that are difficult to make gain weight. So this can be an alternative to recurrent dilation, but not only. Also, it can be an alternative to esophageal resection anastomosis and to esophageal replacement. And you will see we have also more complicated situation that we can use esophageal stenting. Now we will move to the indications. Esophageal stenting that can be used in all kinds of stricture, peptic stricture, anastomotic stricture, but mostly we use it in our experience in caustic stricture. In the literature, it's indicated in case of failure after 3 sessions of dilation. But more than this, we can use it for more attractive indications. And we can find in literature, for example, persistent anastomotic leak after esophageal atresia repair, or it can be used as a bridge before the final treatment in some complex situation. For example, here you find this situation in which we have a tracheoesophageal fistula in a patient that was very difficult to manage, that was intubated due to recurrent pneumonia. So the solution for this patient was to put the stent and to extubate the patient, allow him to eat, to gain weight, and after to do the surgery with success. Now we will move to our third question, how to choose the appropriate stent. This is a very important question. And I remember that my 2 masters, Dr. Monji Maki and Dr. Lasat Sahnoun that is present here, are always discussing about this because this material is not cheap. And there are some rules that you must respect to choose the right material and to have a successful procedure. You must know that there are different types of stents, different material like steel, nitinol, plastic, and biodegradable material. We have different designs. We have different luminal diameter, and we have different radial force exerted and different rate of flexibility. Here, I will describe only 3 types that we are using in Monastir. First of all, we have self-expandable polyflex stents. This is the only plastic stent that is commercially available. As you notice here, the top of the stent is flared in an effort to reduce the migration rate, excuse me. This device is extensively used in the treatment of benign conditions in adults, and it can be used in children as we have some devices with a suitable diameter and suitable length. But the problem with this stents that we will need general anesthesia to put the stent, and we need general anesthesia to take off the stent. That's why the engineers created biodegradable stents. In this stent, the integrity and the radial force will remain for 6 to 8 weeks, and the stent degradation will occur after 12 weeks. And there is no need for removal of the procedure, but the issues are the cost of the devices, and also it needs experienced practitioner. Finally, we'll describe this fully covered tracheobronchial stents that are manufactured to be deployed in the tracheobronchial tree. So here we'll have smaller diameter, and that can be suitable for pediatric population, especially for neonates and also for infants. And it's used for cases of leak or in cases of tracheoesophageal fistula. Whatever the stent that you will use, there are some rules that are mandatory, whatever the stent you use. So the right stent should be at least 2 millimeters larger than the estimated lumen or least dilatation. it should be 4 centimeters longer than the stricture, because it should be placed at least 1 centimeter or 2 centimeters above and below the stricture that is treated. So you understand that we need here a careful study of the esophagogram before choosing the stent. Now we will describe briefly the procedure. So this procedure is done under general anesthesia. We need endoscopy and fluoroscopy to define the ideal location of the stent placement. Here we will begin by the endoscopic balloon dilation. After we will insert a guide wire, we will put our stent, we will verify that our stent is in the right place, and also we will verify if there is any complication, any leak, any perforation by injecting water-soluble contrast material. Here also we must have the forceps that must be available in case we need to remove the stent or to replace the stent using endoscopy. For the steps to put the stent, you should follow the instruction for the manufacturer. There are different regarding the device you will use. After the procedure, the protocol that we are using in Monastir, the patient is under fluid diet for 48 hours. We use corticotherapy protocol and anti-reflux regimen, especially if the stent crosses the ozogastric junction. And of course, we should perform a chest radiogram to confirm the appropriate stent position. You see this example of esophageal stricture. Here you see the stent with fluoroscopy, and here the radiology assessment, and here you see that the stent is well placed. It's 1 to 2 centimeters up and 1 to 2 centimeters below the stricture. So what about the complication? We can have immediate complication like technical failure, aspiration, airway compromise, malposition, stent dislodgement, and perforation. We can have also early complication like bleeding, chest pain, nausea, and we can have late complication like recurrent dysphagia, migration, tracheoesophageal fistula, and bleeding and aspiration. So here we will describe our experience in Monastir. So in a period of 11 years, we performed this procedure in 19 patients. The mean age was 4 years, and the main cause of stricture was costing. It was only one case of anastomotic stricture. For the results, the average time in our series was 14 minutes. We had one case of perforation that was managed conservatively, and we had 8 cases of migration, which required the stent to be removed or reset. So here you see in this example, the stent that migrated in the stomach. And here we performed an endoscopy to take this stent off, as you see in this example. You must know that this is the most common complication that we see after the stent procedure, and it's seen in 40% of the cases, and it's seen especially for covered stent, little stent, and the stent that had put it in the upper esophagus. For the other complication, we can have chest pain. We observed this in 2 cases in our series. For our series, all the stents were removed successfully after 3 weeks to 10 weeks, and 3 children will need esophageal replacement, and 4 children will need further dilation. So in conclusion, esophageal stenting in children is a safe, quick, and reliable procedure. The majority will not require further intervention, and the patient selection may be sometimes difficult. The stent migration is the big issue in this procedure, and it's also observed especially for covered stents. In the future, certainly we will have better devices, and we will have surely other indication for esophageal stenting in children. Thank you very much for your attention.
Thank you very much, Amin, for this very good lecture about stenting in esophageal stricture, and you explained very well this procedure and our experience in the stenting in the stricture, esophageal stricture. So we can, I invite Dr. Qarqni to present the question to Dr. Haddad.
Yes. So there are technical questions about the surgery. So Kausar Bishrat from Algeria asks, what about the fixation of the fundus to the diaphragm? There is another question about fixing the funduplication to the...
One by one, Yusra.
all the technical questions, I tell them so that Dr. Haddad will answer them.
Okay.
So the fixation of the fan duplication to the esophageal hiatus. Is it preferable to fix the cuff to the esophagus in Nissen fan duplication? And what is the best type of suture material? Do you use bougies or not? If not available, can we use nasogastric tube instead? And so these are the technical questions.
Right. Thank you very much. Can I start answering?
Yeah, yes.
Right. First of all, there is no need for fixation of the actual fundus or the wrap to the diaphragm or to the hiatus. A lot of studies had shown that there is no difference whatsoever. It depends on what you like. I mean, you can, of course, fix them to make sure that you are doing the right thing, but there is no need to fix it. If you do fix it regarding the suturing, you can use the non-absorbable material in fixing these. The other thing is, do we fix the wrap to the esophagus? Yes, because the first stitch I use, we just only put gastric to gastric, like fundus. And then the second is the fundus to the esophagus, esophageal wall, and then to the fundus. I use Ethibond 2O Vicryl to do that. Now, the other question about the use of bougies. I started using bougies originally when we started doing Nissen's fundoplication at the 97, 98. And I found there is no need to use the bougies because you achieve a flobby Nissen's fundoplication by testing the actual wrap by introducing the 5 or 3 millimeter instrument underneath it and making sure that it is flobby to do that. But you can, of course, use the bougies. And I did show a slide where the size of the bougie in relation to the weight of the patient. Usually we put a nasogastric tube to start with, and patients who do need to have a gastrostomy, we carry out the gastrostomy as I shown in the video. But also you can use the endoscopic percutaneous gastrostomy, making sure that the wrap is undisturbed if you do that. And there are many ways of doing the gastrostomy, whether it's at the same time or whether it's later if needed.
Talking about gastrostomy, there is another question. Is it used routinely in neurological patients? And I'll add to this question, is the decision of doing a total fundoplication or a partial fundoplication means in these patients? Yeah. The neurological patients.
Right. In neurologically impaired patient, it's very essential to actually use a very flobby or partial fundoplication or partial lap, which means about 270 wrap rather than instead of 360 total wrap in the neurologically impaired patients. And all the neurologically impaired patients, it's better, like in cerebral palsy, it's better to carry out a gastrostomy in these to help at least with initially of nutrition and also decompressing the stomach. We don't use that in other patients, but also we found that in cardiac patients, it's essential to carry out gastrostomy. And if they are not needed afterwards, you can remove them. That's absolutely fine. But in neurologically impaired and in cardiac comorbidity, yes, I do advise using the gastrostomy.
Okay. There is 2 questions from Dr. Nouri asking about the relation between cardiac disease and failure surgery, and about the long-term follow-up of Nissen procedure, the ratio of this disruption of the valve after 5 years.
Destruction of the RAP.
Disruption of the valve, the funduplication.
Yeah, okay. I was going to show the study that we actually done from 1997 to when we started doing laparoscopy to 2007, which is 10 years of patients. These patients, the majority of them were in the Brompton, which is actually a tertiary cardiac and respiratory center. Cases with cardiac disease and also cystic fibrosis and neurologically impaired were carried out. We found from these, we carried out 137 fundoplications. And in these cases, we found that the cardiac disease patient have more problem, or they are better predictor of failure of the RAP rather than the neurologically impaired. Neurologically impaired, we found 64% incidence of cardiac cases. They have problems or failure, in which neurologically impaired, we found about 50 to 54 of these. The recurrence rate in these cases is about 7%, and the rate of redo of recurrence, that's in the first 5 years. The rate of surgery is about 4% of these cases, and some of the recurrent cases, we done a third fundoplication, a third time fundoplication in these cases.
Okay, thank you. Can I ask last questions?
Yes, go ahead.
So in the indication of surgery in gastroesophageal reflux disease, we said that Barrett esophagitis is one indication. If we see this aspect, should we underwent surgery even if there is no metaplasia, and even if the patient is responding well to PPI?
Yes, once there is a Barrett esophagitis, then it doesn't matter if you have metaplasia histologically or not. I think I would indicate having a fundoplication, because you don't know later on how this is going to proceed to a severe Barrett's esophagus, and also changing in the histology of and the presence of metaplasia. So I would, it is an indication for that. Now, what I would like to say also, that failure of medical treatment, if you say failure of medical treatment, optimal medical treatment in such cases, that if you do the surgery, it doesn't mean always that you will have successful thing, because the more that they are resistant to medical treatment, the likelihood that they will have problems and recurrence of symptoms. The things about the complications which they asked earlier on, the disruption of the RAP, as I said, we had that in about 7% of cases, and we had 2% of cases where there was migration of the wrap into the chest, which we needed to repair the actual hernia and bringing down the wrap. And I remember in 3 cases, I have to undo the wrap and redo it again.
Okay, thank you. No more questions.
Okay.
So Dr. Qsia, if you have questions for Dr. Sawyer.
Yes, we have questions for Dr. Sawyer. First question, what anti-reflux medical treatment are you using after repair of esophageal atresia, and how long?
About medical treatment?
What anti-reflux medical treatment are you using after repair of esophageal atresia, and for how long?
I use the PPIs for the first years of life. And at the end of the first year, according to the symptoms, if there's no symptoms, everything is going good, and I stop the PPIs. But if the patient has some symptoms and like aspiration and respiratory problems and strictures, then we can continue. But before continue, sometimes we need to see a pH monitoring or impedance that we're going to sure about the reflux. The PPIs in the first line treatment for the first year.
Okay. We have a comment from our friend Oliver Monsterer about the pH probe. His comment is, I do not find pH probe very useful. I go by clinical symptoms and endoscopy with biopsy. If the esophagus looks good and there is no inflammation and the kid has no symptoms, I don't care what the pH probe shows. And on the other hand, if the kid has symptoms or there is significant esophagitis on the biopsy, when the child, then the child needs treatment, and no matter what the pH probe shows. Do you have any comment?
Yes, I also, it's not a rule. It's a rule that all of the patients have some degree of reflux, and therefore to do pH monitoring or impedance to all of the patients is not logical. But in some cases, if you need to go, if you have ongoing problems, or if you have some recurrences, especially, for example, if you have a stricture and if it's going to be an anastomotic stricture before 1 year of age, usually, and it resolves by 2 or 3 dilatations. But if there is a resistant stricture, and if the baby have a stricture after 2 years of age or 3 years of age, then you have to test the pH monitoring, because you have to show that it is about reflux. And if it's about a reflux, you have 2 dilatations, and after that you have an anti-reflux surgery. Therefore, I agree to Oliver. It's not to do the all patients as a routine procedure, but some patients with recurrent symptoms and ongoing symptoms and some atypical symptoms, then you may need to do a pH monitoring.
Okay. I have a personal question about eosinophilic esophagitis. When you will suspect it?
Yes, very nice question. Thank you, Amine. You know, the patient with esophageal atresia has increased risk or possibility of eosinophilic esophagitis. So if a patient with esophageal atresia has no anatomical or mechanical strictures, have no reflux, but still have food impactions, then another possibility is about the eosinophilic esophagitis. Therefore, endoscopy is a very good diagnostic tool to understand and to see the eosinophilic esophagitis, because there are lots of endoscopic features that you can see. For example, trachealization of the esophageal mucosa, and also some typical narrowings. And if you have the biopsy, and if you see in the biopsy the eosinophils in more than 50 in a patient with under PPI or without PPI, then you have the diagnosis of EOA. And then you need to another treatments like steroids, like to testing for atopic diseases, allergic diseases, and you need the pediatric GI specialist to help you to resolve the problem. So it's a very good question, and we have to keep in mind that EA patients may also have eosinophilic esophagitis.
Thank you for your response. How to prevent esophageal stricture after esophageal atresia surgery? Do you have some tricks?
So very good questions. You know, it's very common and well known that if you have an tension-free anastomosis and with a good vascular supply, you're not waiting in anastomotic strictures. But if you have a tensioned anastomosis or difficulty in anastomosis, and if you have some leaks after the procedure, then it's going to be healed with strictures. Therefore, if you have a good surgery, if you have a good esophagus and a good length, you have the better results. But if although it's not proven in the literature, as I told in my presentation, we use PPIs for the first year, and if you avoid some acid exposure, then maybe we can avoid a little bit about the strictures. But there is no extra thing that we can prevent the strictures. But we know that the anastomotic strictures are usually easy response to the dilatation treatment. The question is whether you have more resistant strictures that then you have to look at for reflux disease and eosinophilic esophagitis.
And in case of anastomotic stricture after surgery, when you start the dilation?
When the patient becomes symptomatic. If there is food impactions, there's difficulty in swallowing, especially solid foods, and especially they have narrowing in the upper GI studies, then if the symptoms, then we're going to perform an endoscopy and we put a guide wire and have a dilatation. Not wait for it. It's only this. So being symptomatic is enough for the indication.
Now, question to you and to Dr. Haddad also. Do you use prosthetic material like mesh to reinforce the hiatus? You know, sometimes to avoid the migration of the stomach in the chest?
Yeah, I never need in EA patients, and there is no need for EA patients. I think it's very easy to narrow the hiatus during the different application. I never used.
Dr. Haddad?
Neither me. I don't use any mesh or pledgets or anything like that. I have not used it yet over the last probably 25 years.
Okay. Some questions for Dr. Qarqni.
Yeah.
So can you give more explanation about not using positional therapy in sleeping baby and why?
Despite possible benefits to positioning in the treatment of reflux, no position other than supine position is recommended because of the risk of sudden infant death syndrome. So supine sleeping is universally recommended as the safest position.
Okay. And what is your gold standard for the diagnosis of gastroesophageal reflux disease?
There is, as I said, there is no gold standard for the investigation in gastroesophageal reflux disease. It's the clinical symptoms, and then we perform if there is a complication. We do a fibroscopy as if we are in front of esophagitis, we'll do a fibroscopy with biopsies. If we suspect disorder motilities, we'll undergo manometry. So there is no gold standard investigation, but we tend to prescribe pH metry. We can consider it superior for all these investigation. pH impedance monitoring are more is superior to pH metry, but it's an exam that is not available here in Tunisia, and it's very expensive.
Okay.
There is another question to Dr. Sawyer. Is about esophageal structure after GERD. Did you first perform dilation or fan duplicature procedure? Is the stent is a good procedure for this indication? Then the structure is total. Dr. Sawyer?
It's for me?
Yeah.
Okay.
It's about esophageal structure after gastroesophageal reflux. Did you first perform dilation or fan duplicator procedure?
Yeah, I perform a dilation firstly, and afterwards I do a fundoplication, because if you have stricture and if you have a fundoplication and total fundoplication, then the postoperative dysphagia is a severe problem. So first dilation, therefore in the preoperative assessment, we always perform an endoscopy to see if there is a stricture, also to have a biopsy to see if there is an esophagitis before the fundoplication.
Okay. Some question for Dr. Qassia. Very salutation from Mohammed Debiki, our friend. So he speaks about our experience in Monastir, and he wish here a detailed description of our the experience in Monastir. So I said him, so we can discuss friendly with Mohammed with our experience. And there is a question for how do you manage stent migration? I mean,
so for stent migration, this is the most common complication that we can see after stent procedure, stenting procedure. We usually perform endoscopy and try to remove the stent. Sometimes we can replace the same stent and do the dilation in the same time, and sometimes we will take it to take it off.
Yeah, I think there is
Can I comment on that, because I agree entirely with Dr. Amin regarding that migration is the most common problem in these cases. And I had two cases where the migration reached the ileocecal valve, and we have to actually do laparoscopic introtomy and removal of the stent in these two cases. So beware, sometimes even if they go into the stomach, they don't have symptoms until they go a little bit further into the intestine.
Okay. Okay, another question, Dr. Qassia, depending on which criteria or rule you decide to remove the stents. Thanks.
Usually we wait for 6 weeks, 8 weeks.
Yeah.
And we will remove the stent after, and we will see if it's efficient or not.
I mean, salutation from Dr. Zaki, Ahmed Zaki, past president of APSA. So, and he finds very good idea for stent for especially corrosive structure. So, salutation for our friend, Dr. Ahmed Zaki, Midhat Zaki.
It's an honor to have him.
Is there another question? I think.
I see two questions, one from our friend from Hanover, Dr. Najud Shukfe.
Yeah.
And perhaps I need your help here, because she told, do you have any experience with stenting a very proximal anastomotic stricture after gastric pull-up? And she said that she tried it one time for a 6-year-old patient and he did not tolerate it. Personally, I don't have any experience, and you, doctor?
No,
I don't know if
no, we don't do gastric pull-ups, so we haven't. Yeah.
We do.
Can I just comment? It's very difficult
to
do or put a stent in a pull-up, in gastric pull-up, because the anastomosis is very high. And as Dr. Amin mentioned, that you need at least 1 or 2 centimeters above that. So it's very difficult, and they usually do not tolerate it. So I entirely agree that it is very difficult, and you don't need to use it. I mean, it's the children do not tolerate it. Can I just have a question to Dr. Amin?
Yes.
Do you use any topical steroids?
Yes.
We use after the procedure, we use steroids.
Yeah. Okay. Not intraoperatively.
No, not intraoperatively. No.
There's a question for Dr. Sia from Algeria, asking if the stent immigrate to the stomach, what would you do?
Yes, we will do endoscopy and try to take it off, but sometimes, like Dr. Haddad told us, sometimes it goes more than this, and it's more difficult to manage. There's one question for, I think, Dr. Haddad and Dr. Tutko-Sawyer for pyloroplasty.
Yeah.
Do you perform pyloroplasty after fundoplication?
Do you want me to answer it first, or Dr. Sawyer?
Yes, yes.
Yeah. No, it is not actually sort of indicated. If there is inertia, usually we do electrogastrography in these cases. If there is a problem with stomach emptying, I think the fundoplication itself should promote that. I started years ago. I've done about 3 or 4 pyloromyotomy rather than pyloroplasty in these cases, but I don't find it very helpful at all. And the studies from Los Angeles and other centers showed there is no difference in either doing or not doing pylotomy or pyloroplasty. I don't know what Dr. Sawyer experience in this, but that's my experience.
Yes, I also agree, Dr. Haddad, because there is no use, and I never do it routinely in a pyloromyotomy or pyloroplasty. There's no use, but we usually do not gastric collapse cloning interpositions for replacement surgery, but as far as I know from some Turkish colleagues, when they're doing gastric collapse, they routinely do pyloroplasties. But otherwise, normally in fundoplication, no, we never use.
Yeah,
no
yeah. If you are doing the gastric pull-up, it is actually worth doing pyloromyotomy or pyloroplasty because that will help, because the stomach is already in the chest. But for fundoplication as a treatment for gastroesophageal reflux disease, there is no need and there is no difference in the outcome.
Yeah, I agree.
I think that's all. I don't know if there is any comments, any question before we conclude. Dr. Sahnun perhaps will conclude.
I don't see any another question, so we can conclude. We conclude with we must thank Dr. Haddad and Dr. Sawyer for this excellent lecture, and Dr. Qsia, Dr. Qarkhni, and all Qais. He's the messy of the Zoom webinar. So and we must thank also InfoPoint and Dahlia Laboratory for associate to and participation to success this webinar. So I let our guests speak about this webinar. Dr. Haddad.
Right. Well, thank you very much for inviting me to participate. And this has been an excellent webinar, and I did enjoy it from all the speakers, and I did learn from it. So that's very interesting webinar, and hopefully we'll have more webinars on discussing certain subjects.
Sure.
I really enjoyed it, and thank you very much for everybody, and thanks for the audience for the questions as well. And it's lovely to see you through the webinar, and friends from Tunisia and other countries. Thank you very much. It's an excellent webinar. And I would like to thank the technical assistant, ICE, and the others for a very well conducted webinar. Thank you.
Dr. Sayer?
Also, it was a really great pleasure and honor for me to participate in this webinar, and I really thank to all the Tunisian Association of Pediatric Surgeons and all colleagues. I really enjoyed, and me too, I learned a lot of things from this webinar. And I would like to congratulate all the team and the technical team to making us easier and making us enjoyable to the all staff and doing everything. And it's going to be also a great pleasure for me to see all of you in Turkey, and have a good evening. Thank you very much.
Thank you very much. Dr. Qsia?
I wish to thank all the audience, all our invited lecturers. Really, the presentation were awesome. And I hope that we will see together physically the other times.
Yusra?
I want to thank our two guests for having answered favorably to our invitation to participate in this webinar. You are from now on one of the privileged guests of the Tunisian Association of Pediatric Surgery, and we hope to matter your support during our next appearances.
Okay,
Thank you. And you will have my support, and I will invite you for the next BAPS meeting, which we couldn't do this year in Bruges in next year. And I gather you had some presentations also, so you will be welcome there physically.
Inshallah. Inshallah.
Our colleagues from Tunisia and all our colleagues worldwide. It's a pleasure to have you. If COVID can allow us, do it.
Thank you, Dr. Haddad. Thank you, Dr. Sawyer, and Dr. Qsia, Dr. Qarqni, all the participants, and all our friends from all over the world, Egypt, Libya, South Africa, Morocco, Algeria, Turkey, Britain, England, and from also Arab and Saudi. So we will see you maybe in another webinar.
Very soon.
Physically, it will be better. Okay. Thank you.
Bye-bye.
Bye-bye.
Thank you, and good night, everybody. Have a nice weekend. Thank you.
Okay. Thank you very much.
Thank
you, Qais. Thank you, Qais.
Thank you.